Hello, good evening. As I welcome you to Kolkata Live 2022. This is our day one, and I'm Dr. Binayak Deva. I'll be moderating the show. We'll be discussing on some case discussions, and we'll have some talks as well. And we have with us expert panel. First of all, we have our course director, and who's also an expert panelist, Dr. Shobhanan Rai. And also we have with us Dr. Shubhra Banerjee, Dr. Pramod Kumar, Dr. Prithviraj Bhattacharya, and Dr. Dilip Ratnani as our expert panelists. We have an array of speakers, international and national speakers in form of Dr. Aisha Kadir from Bangladesh. We have Dr. Devalko Dua, Dr. Mandar Shah, Dr. Pranay Jain, and Dr. R.K. Jha. So let me first introduce the concept of Kolkata Live. We have been doing this since June 2021, and we have done quite a few meetings, and it's been very successful. And I have the privilege of starting our 2022 with Kolkata Live's meeting today. And we'll be discussing definitely on some important cases from Dr. Aisha Kadir and from our national speakers as well. And then we'll have 15 minutes case presentations followed by discussion at the end of 3 cases to begin with, and then 2 cases later on. So let me introduce Dr. Shobhanan Rai, who does not need much introduction. He is a good friend of mine and also Director of Interventional Cardiology at Fortis Hospital, Kolkata. I've been given a huge curriculum about him, but he does not need much of introduction because he has so much years of experience in complex PCI management. He's been an excellent teacher over the years, and he has advocated some new emerging therapies and techniques, in particular in the bifurcation, and he has published innumerable articles in reputed national and international journals, and also authored a guide for students who are being introduced to the world of interventional cardiology. With these words, I welcome Dr. Shobhanan Rai to our meeting and to conduct the course. We have Dr. Dilip Ratnani, who is the head of the department and director of cardiology department at Sri Shankaracharya Institute at Bhilai, Chhattisgarh. We have Dr. Prithviraj Bhattacharya, who is a senior consultant in interventional cardiologist at Fortis Hospital, Anandapur, Kolkata. We have Dr. Pramod Kumar, who is published notable papers and a director and head of the department of cardiology in Jayaprabha Medanta, Patna. And he has completed his DM cardiology from Delhi University, and he's performed plenty of procedures, interventional procedures. His expertise lies in the area of cardiovascular surgery, angioplasty, and angiography. Dr. Kumar has been a part of several national and international conferences, and he has headed the Institute of Heart and Vascular Disease at Jaipur Golden Hospital. And we also have Dr. Dilip Ratnani, who is head of the department and director of cardiology department at Sri Shankaracharya Institute at Bhilai, Chhattisgarh. So with these words, I introduce our expert panelists. And then, of course, I would like to start off the session with Dr. Aisha Kadir, who is a good friend of mine, and he's a very well-known interventional cardiologist at Dhaka and also a very good speaker. We have had her in our previous programs. And she's just changed her topic, so she'll be talking about the topic very soon. But let me introduce her. She's assistant professor of cardiology with an interest in interventional cardiology at Ibrahim Cardiac Hospital and Research Institute, Dhaka, Bangladesh. She has research interests in cardiovascular clinical trials, population health and outcomes in acute coronary syndromes and coronary intervention, and is undertaking a part-time MSc in clinical trials at University of Oxford. Dr. Kadir is a social media editor of European Heart Journal. He supports. She is a member of SKY's Women in Innovations Committee and serves on the AHS Council on Clinical Cardiology Leadership Committee. So I welcome Dr. Kadir to our meeting, and if you could start your presentation, and over to you, Dr.
Thank you.
Shobhanan Rai, for the next session. Thank you.
Thank you very much, Dr. Deb. It's always a pleasure to present at Kolkata Live, and thank you for the very kind invitation as well. So since you said it was poetic, I'm just leaving it as is, and presenting my case. So this was a 75-year-old elderly, frail gentleman, typical South Asian elderly gentleman who was hypertensive, diabetic, and dyslipidemic, presented this time with intractable angina for the last 2 to 3 months, which was increasing in intensity despite being on optimum guideline-directed medical therapy. His ECG showed a poor progression of R wave, and the ejection fraction was relatively well preserved with a 55% with some inferior wall hypokinesia. So because he was kept on medical therapy and was not responding, we proceeded to coronary angiography. And this is the left system. As you can see, there is severely diseased and diffuse calcification of the LAD. It's very visible even on angiography, and a significant discrete tight lesion in the proximal part of the principal OM. On RCA, we found that the RCA was codominant, somewhat tortuous with a tight lesion in its mid part, and actually TIMI 2 to 3 flow because the lesion was so tight with some degree of calcification, but which was not very visible. So this is a case of triple vessel disease with an intermediate grade syntax score in a frail HBR gentleman who fulfilled certain criteria for high bleeding risk, who was elderly with multiple comorbidities. So we typically adopt a heart team approach for such cases, but given the frailty, and as we know in the subcontinent, 75 is not really 75, it's something around 80, the surgeon wasn't particularly interested in taking him on. Neither were the patient's family. They also declined CABG, so we had to proceed for PCI. So in that case, what sort of strategy? We figured that intravascular imaging would be mandatory here, and all available modalities that we had in the table for calcium modification were deployed and kept ready. And considering the comorbidities, we also wanted the procedure to be as brief as possible, as fast as possible, and swift. And given that it's triple vessel, we decided that we will first go to the LAD, which was the one that we thought would present the most difficulty, and depending on how that went ahead, to go ahead with the rest of the vessels. And we also kept in mind that this is a case during the pandemic, and to have elderly patients come in and out of hospital repeatedly for procedures was a consideration. So we decided to revascularize as many lesions as possible here. So we proceeded to, as we said, wire the LAD with using a 6 French jail guide here. And as you can see, we managed to get an IVUS catheter down first to assess the calcium. And you can see there's napkin rim calcium extending across a very long segment of that particular mid LAD. So given this very concentric calcium, we decided to go for an upfront rotational atherectomy to minimize the risk, minimize the other procedures as possible, and went for an 1.5 millimeter rotaburr at 160,000 revolutions per minute. After about 3 runs, we then did a further lesion preparation with a 2.75 millimeter non-compliant balloon, and then put down an IVUS catheter. As you can see, the calcium has cracked quite a bit in most of the segments, and we therefore then decided to proceed for stenting of the lesion. We deployed a 2.75 38 millimeter drug-eluting stent guided by IVUS, and post-dilated that with a 310 millimeter NC balloon with a satisfactory angiographic result, as well as an IVUS result with good stent apposition and no edge dissections. Seeing as this went relatively smoothly and according to plan, we then decided to also do a spot stenting of the principal OM with the 2.58 millimeter drug-eluting stent. We did not use IVUS guidance for this. It was relatively straightforward. And then we went on to the RCA in the same setting. So we wired the RCA with difficulty, and also required balloon support because the microcatheter was just not crossing that. So this is really where we saw that calcium somewhere indicates that there is probably calcium everywhere, because we did not anticipate as much difficulty in revascularizing this lesion, but it presented the most difficulty. We had to go with 1.255 millimeter balloon support, and then did a small balloon inflation there. But beyond that, no balloons were crossing at all. So we then decided to take a 6 French guidezilla. This was a 6 French JR guide, we took a 6 French Godzilla and then took a 2.8mm NC balloon and gradually upsized for sequential predilatation with 2.515 NC. And then we also took a scoring balloon in order to maximally prepare the lesion, because we couldn't get an IVUS catheter down until all of these lesion preparations were done. Subsequently, we managed to take an IVUS catheter down. The calcium was not as concentric as in the LAD, but as you can see, there is eccentric calcium. And we then decided, as there has been some degree of cracking of calcium and the lesion seemed relatively adequately prepared, we decided to take down a stent through the Godzilla. So we took a 3x30 drug-eluting stent, but as you can see, the stent would not cross beyond this segment, this late mid segment of the RCA. And we thought perhaps there is calcium there that was protruding and was obstructing the stent. But we also then took the stent within the forearm and saw that it wasn't really crossing this distal tip of the Godzilla either. So the stent was not entirely being able to cross across the Godzilla, and that was really the problem. This was, needless to say, an Oxford Godzilla. So we then took out the entire system, which was retrieved from the forearm, and found that this excessive manipulation, along with the problem in the Godzilla, had caused a stent fracture. And we had to then change the entire system. We took a brand new Godzilla, then first observed the stent passing through the entirety of the Godzilla catheter across the forearm. We made sure that was done so that that problem was solved, and then decided to stent along with the Godzilla. But as you can see, even here, even despite the Godzilla, there was a significant necessity for some very good manipulative active support for it to cross the lesion, even though there was the presence of Godzilla. And finally, with an expert hand, this particular segment was really performed by my mentor, Professor Syed Rahman Khan. A 3x30mm drug-eluting stent was deployed in the mid RCA, delivered through the Godzilla, and with a satisfactory angiographic result. Given that there was quite a bit of manipulations being done, then we didn't really go for an IVUS afterwards and decided to stop here with the satisfactory angiographic results. The patient has been chest pain free. We kept him on aspirin and clopidogrel, given that this is HBR and an elderly patient. And he seems to be doing well since then, as of 4 months follow-up. So in conclusion, I suppose we could say that calcium somewhere potentially denotes calcium everywhere, and that RCA calcification is something we should have anticipated, particularly in an elderly gentleman as well. Intravascular imaging is key to identify the degree and arc of calcium, as well as tailoring strategies accordingly. We need to keep the full armamentarium ready for where it's needed. Of course, there are limitations in that we don't have the full armamentarium at our cath lab. To the IVL might have been a very great addition to tackling the RCA there in terms of preparation. So be it simpler strategies like a guide extension or even specialized equipment, we need to make sure that the armamentarium is ready to be deployed appropriately and accordingly. And of course, we always need to be prepared for all types of complications and hiccups, even in the form of guide extension catheters. And this is really a very nice algorithm that we like to follow. It's a MASA where you assess, modify, assess, stent, and then reassess. So intravascular imaging, and depending on the arc of calcium and of course the balloon crossability and dilatability, to modify the strategies accordingly. And this case was a nice demonstration of the myriad of presentations of calcified lesions, where it can go wrong, and also which strategies to adapt. So with that, I'll stop. Thank you for your attention. I'd like to acknowledge my mentor, as I said, Professor Sarkhan as well, and thank you for the opportunity to present.
Thank you, Dr. Kader. I think we will go on to our next case, and then we'll take some questions with you. I invite our next speaker, Dr. Devargo Dua, who is a consultant cardiologist with the Mission Hospital, Durgapur. He has more than 5 years of experience in the field of interventional cardiology and has published notable papers in reputed national journals. He's a skilled operator in the interventional cardiology space and is accustomed to procedures like CRTD, septal ablation, peripheral angioplasty. So with this introduction, we'd like to invite Dr. Dua for his presentation. Over to you, Dr.
Thank you, sir. Thanks for the introduction. So this is Dr. Devarkar. Am I clearly audible to you, sir?
Yes, you are. And your slides are visible as well. Please carry on.
Okay. So this is Dr. Devarkar from the Mission Hospital, Durgapur, presenting a case of 62-year male who presented to us with LVF at presentation, which was stabilized medically, and the patient was non-diabetic as well. And he had a history of non-STEMI NST elevation MI 9 months back, for which he was hospitalized in a different hospital. And there an angiogram was done, which showed DBD, RCA total occlusion and L6 total occlusion, and LED minor plaque. At that time, he was advised to undergo CABG, which was declined by the patient and his relatives. So we managed the patient medically, first of all, as he was having heart failure. And then we did an echocardiogram, which showed there is a regional wall motion abnormality in the inferior wall with preserved thickness. And his LVEF was something like 40%, and there was mild MR. So coming directly to the angiogram, we saw the same picture that was there 9 months back. There is a non-dominant LCX, which is totally occluded. There was no significant OM originating from the LCX. The LED lesions were actually non-stenotic or non-significant, and there was good choroidal flow to the RCA. As you can see from this picture, the left side of the picture can also be evaluated to see a bunch of calcium, which is a tram track calcification in the proximal to mid RCA, which is nicely visible from this picture. And now we took a shot from the left side in a LAO view, the view we use while taking a shot in the RCA to assess the length, the approximate length of the CTO segment. And from this picture, we can assess that there is a calcium part, calcified part, which is around 15 to 20 millimeter. And then there is a 20 to 25 millimeter distal part. And then there is the visible retrograde flow up to the almost to the mid segment or distal segment of the RCA. And the RCA was actually occluded from the osteoproximal region. And here we can also see the calcium segment, calcified segment, which is around 15 millimeter away from the visible ostium. So actually it's a long CTO of RCA. We didn't think of LCX. I mean, that was non-significant, that was non-dominant actually, and there was no OM. So the only option left with is PTCA, because we do not do CABG, we do not prefer CABG for single vessel disease. Although the patient was given a choice of CABG for a single vessel disease vis-a-vis PTCA to the RCA, which is a CTO. So in this picture, what we got is an osteoproximal cap, and then again there is a branch originating from the cap, a side branch. There was calcium, visible calcium or tram track calcification, and the CTO was having a long segment. So we started PTCA to RCA. We took a XB RCA to have a good support, and we took Gaia third for its good penetrability and trackability with the help of fine cross microcatheter. But whenever we are trying to puncture that CTO segment with the Gaia was invariably tracking the side branch. It was entering into the side branch again and again. So what we had to do is to block the side branch by a run through extra floppy wire. Then we took a CrossFit 400 for its sheer penetrability or penetrating force. And after some times, we were able to puncture that CTO segment in a different plane. That calcium actually helped us to assess or assume the track. So we followed that track, and after puncturing the CTO segment with the CrossFit 400, it did not track as easily. So we again exchange it with a Gaia third with the help of the fine cross, and the Gaia third actually crossed the CTO segment, tracking it nicely, and it entered into the side branch, look like a side branch. So we took a contralateral shot from the left system to check the position of the wire from two orthogonal views. And after adjusting the wire into the main lumen from the side branch, we were somewhat sure that the wire was actually in the true lumen and tracking in the good direction. So we were able to cross the CTO segment and entered into the distal RCA with the help of Gaia third wire. But the real difficulty came thereafter. We could not cross the microcatheter downward. It was a fine cross. So we tried, first of all, we tried to cross the fine cross, but it didn't cross the CTO segment. Then we tried to open up the CTO segment with 1.2 into 10 NC balloon, which also failed to cross. Then we took 1.2 into 10 U-ray balloon, which has got a finer crossing profile, but it also failed to cross the CTO segment. So at this point, we were very hopeless, and we thought that this is our moral victory to cross the CTO segment, and we have to be happy with it. But whenever we were taking the balloon out, I mean the 1.2 Ray or 1.2 NC balloon out, we found that the balloon was gripping the wire very tightly, and we had a very difficult time to pull the balloon out because it was catching the wire very tightly. So we thought there was a problem maybe in the coating of the wire so that the balloon could not track, or maybe due to the calcified segment it could not track. So the only option we were left with is to change the wire, remembering the fact that if we lose the track, we may not be able to cross it again. So we took the wire out, Gaia 3, and we find there was a microchannel formation, which was done by the 1.2 balloon dilatation up to the mid of the RCA. Then we took a Sion black wire, as it can track the channel very nicely, and thankfully it tracked the microchannel nicely and went into the distal RCA segment. And after taking this Sion black, we found that 1.2 into 10 Ray balloon easily crossed the CTO segment. So we began our pre-dilatation gradually with 1.5 into 10 NC balloon, then with 2.5 into 10 NC balloon. But the 2.5 into 10 NC balloon ruptured. This was an unintended granuloplasty that we had to face when we were pre-dilating the balloon in the calcified segment. So then we took 2.5 into 10 OPN NC. We tried to put the IVUS catheter down, but we were not able to push it down because of the calcified segment was not pre-dilated nicely. So we took 2.5 into 10 OPN NC balloon, and we gave serial pre-dilatation using this balloon up to 40 atmosphere gradually. And after that pre-dilatation, we saw the dissected segment. I mean, the segment was not pre-dilated nicely. So we took 2.5. Then we stented the distal part with a 2.5 into 48 regulating stent, and the proximal part with a 2.5 into 48 regulating stent overlapping with each other and covering the RCA ostium as well. Then we gave some post dilatation with 2.75 into 12. That scene has not been taken. I had to cut it because of shortage of time. So we did give some good post dilatation with 2.75 into 12 from distal to the proximal of RCA. Then we did an IVUS run. This time we were able to negotiate the IVUS catheter, and this is the IVUS run. It's a very long run, as you can assume, because the stented segment was very long. So this is the distal RCA. So it's around 2.5. So we took a 2.5 stent. The stented segment has started. We found the stent was well approached. It's a very long video, 2-minute video, I guess. The stent expansion and apposition looks good to me. This is the calcified segment. We can see almost 180 degree calcium. This is the proximal RCA. Okay, so this is it. And this is our final angiographic result from cranial position. And this is the usual LA view. So this is our final result. We were happy to see this picture. The flow, it was a very long procedure. Actually, the procedure time was 3.5 hours. The flow time was 90 minutes 17 seconds, and we had to use a dye of 200 ml BCPIC. Thank you.
Thank you, Dr. Dua, for your excellent case. I welcome Dr. Shubhanand Roy, who I just introduced in the beginning of our show. He's a course director and expert panelist for this show. He's, as I mentioned, he's the director of interventional cardiology at Fortis Hospital, and he's a very well-known interventional cardiologist in our region and nationally as well, with innumerable articles in reputed national and international journals. And he's also an advocate of new emerging therapies, PCI, and happened to be one of the innovators, one of the steps in procedures in bifurcation stenting. Also, I want to welcome my friend, Dr. Shubhra Banerjee, who is the senior interventional cardiologist at Apollo Hospital, Kolkata. He's an excellent interventional cardiologist. Besides that, he's a very good academician as well. So welcome, Dr. Ray and Dr. Banerjee to the show. I think we'll discuss the first two cases. I would invite Dr. Ratnani and Dr. Pramod Kumar to discuss the first case, and then to Dr. Shubhra Banerjee and Dr. Shubhanand Roy to discuss the second case, and then we'll move on to our next case of set of presentations. Over to you, Dr. Pramod Kumar and Dr. Ratnani for the discussion of the first case of Dr. Aisha Kadir.
Hello. Hi, everyone.
Hi, Dr. Yes, yeah.
Dr. Pramod here. Hello, Shubhanan. How are you? Where is Shubhanan?
He's here actually in the meeting. Yeah. You can carry on with the first discussion.
Yeah, it was a brief comment about the case. Very well done. There is absolutely no doubt. And, they bailed out the RCA very well in spite of getting into trouble. So what she said at the end was that, you must be prepared for everything. You must have everything at hand. And one of the lessons that we have to learn is that, the reuse of things, it gets us into trouble time and again. So we have to do something that when you're doing a very complicated case, it's better not to compromise on the, the O and N and all. Make sure that you have the best things in your lab and you use that. Otherwise, very well done. Absolutely no doubt about it.
Yeah,
Thank you very much.
Dr. Ratnani, yes.
I also emphasize the same thing because today only I was doing one case where I found that I was reusing guideliner, and I could not succeed by radial route, so I had to shift to femoral route, number one, and second I took new Gadzilla. Even then I had problems in negotiating tortuous LAD. So definitely the case was very well done, and we should try to in such type of circumstances, usually the good support is needed, and hence the femoral route is preferable, and of course the rest of the things were tackled nicely, and very well done case. Thank you.
Dr. Kadir, I have a question for you. How often do you use the IVL in this kind of cases, or do you have it in your lab at the moment?
So yes, that's exactly what I was alluding to. I think this is the perfect case, especially in the RCA. If we had an IVL, we don't have it in-house. We have sort of got down the console for a couple of cases so far. And in fact, I was supposed to present an IVL case, but unfortunately I was on vacation back home in Colombo, so I couldn't make the slides. But yes, I would agree. Since this was done about 4 months back, that's not when we had IVL, but I would agree that this is a very good case for that. So it's not very frequent. I think cost will be a prohibitive issue to its frequent use in our setups, but we have seen how well it can be exercised, especially when NCs don't yield the lesion. We had a very nice case just a couple of weeks back where IVL was very well a great way to bail out. Yes.
Yeah, I like your statement about calcium somewhere and calcium is calcium everywhere. That's a very, very good point you made. So thank you very much again, Dr. Kadir, for your lovely case. I welcome Dr. Shubhra Banerjee and our course director, Dr. Shobhanan Roy, to give his comments on the second case by Dr. Dua. Over to you, Dr. Ray.
I think Shubhra should start first.
Okay. Shubhra.
Okay. I'll come next.
All right.
Okay.
Thank you, Dr. Rai and Dr. Dev. It's really nice to see you after a while. I think Dr. Dua's case was really nicely done, and the results looked really good. I have a few questions for him. Dr. Dua, you used IVUS? What was your MSA after this? After you have done the study, did you check what was the minimum standard area?
So it was done actually. I don't remember exactly the MSA. I have to check it. I mean, I don't remember.
That was quite adequate, right?
Yes,
I'm sure that was adequate.
I thought so.
Okay. And the other question was, what about? Did you think about trying the turnus when actually I think you used your balloon it didn't go. Did you think about trying a turnus and see whether that could be effective?
Yes, I did think about it, but only option left with was a fine cross microcatheter. We don't have turnus in our cath lab.
Right.
The microcatheter was 1.25. It was not crossing though. We tried with a 1.2 into 10 relay balloon. It didn't cross. Maybe that was the reason that we had to take the wire out. and took a new wire over which this 1.210 relay wire went through nicely.
Yeah, it was a good decision, I think, because as you have said, probably it was gripping the balloon
Yes,
was
very
gripping the
tightly.
wire, and there could have been some problem with the coating. So that was a good decision. And the other question, and this is a general question to all the panelists, perhaps, in a patient who has, who came in with LVF and has an ejection fraction of 40%, looked like it might have been a bit unstable. Do you normally put in a left groin access in case you think an IBP may be necessary? Or you just, if you run into problems, then only you think about it? I mean, this is a general question. I mean, not really about this patient, but and with this, over to Dr. Rai.
To answer the question which is generalized, before going specifically to the case, basically, Subhra, if I think that in this situation, if you do the LED, this thing, as a single surviving artery, LAD PCI, really an IBP or something circulatory support would have been absolutely necessary. I agree with you. But he has done the CTO first. So perhaps if he could look into the volume of contrast and does not, do a retrograde implant, then I think circulatory assistance might not be necessary as he has done the case. It's a good case. But I have few questions, and I think, and few suggestions to make. Number one, I have seen your case. Why don't you take a floppy well? As for example, channel seeking well like Fielder XT or Fielder XTA, so that it could. There was probably a micro channel which you possibly you tracked later on by the Scion. So if you could take a channel seeking where perhaps your job would have been better done. This is number one. And number two, what is your well like, Gaia? Is it an Oxford well?
No, it was a New York wire.
Okay. Perhaps this Gaia went through some of the channels which is calcified, and it's, coating is somehow, and you have torqued it very well. Perhaps that is the reason why its coating was abraded, and for that reason, the wear did not move. Otherwise, Riure, 1.2 into 10 is a wonderful balloon. It goes like a dream.
Yes.
And which happened when you put a new Sion blue wear, and again it went like a dream. But as because you have taken a heavy duty wear, and you needed to torque it very well through the CTO segment, perhaps calcium and the firm tissue in the CTO has abraded the coating, and that was the reason why initially the balloon was not going. And basically, there are few, I have another small point to make. That is, we live in a country which is very poor, and if I think that in every case I would have all new wares, new balloons, this is a luxury, I believe.
Yes.
And yes, it is ideal, I admit, but this is a luxury to most of us who work in a hospital where patients need to pay from their own pocket. So we need to have innovations. And in your case, I have seen the first, when your guide selection was optimum because you took a very good supported wear. And if you could put another wear and press that wear with a balloon in the proximally, and now you push the whole thing down, you would have more grip, and probably your balloon insertion inside the CTO segment would have been easier, unless you think that there is a abrasion and loss of coating of the wear. If that is the reason, then nothing would have been possible. But in a case where you are not being able to push the balloon through the CTO segment, you pick and take another wear, fix the wear into the wall of the artery by a balloon, and now you push, so it will generate more force and it will go easily.
Actually, nothing was going. I mean,
That
the
is
only
the
thing
reason
that went,
I'm telling you that.
yes, sir.
Because you probably had a loss of coating and your where it's a possibility.
We
But
tried to introduce
otherwise,
another wire by the side of the first wire, but
Hmm.
it didn't go well. I mean, it didn't go at all. And
no,
coming to,
not in the CTO segment, but
yes,
before CTO segment. And you push the balloon with the wire in the proximal part. And now you push this balloon into the CTO.
so that is, I understand. I mean, that's balloon supported guide. I mean, anyway, so we didn't have any problem of support because the guide was abutting the CTO segment very nicely. And the problem was whatever wire we took from the beginning, it was entering into the side branch. That branch which is originating from the CTO segment. So
If you could put a wire into the side branch, now you put the wire in. What you did, that is the way you go into the CTO segment. That's fine.
yes, sir.
That there is nothing wrong in it.
So what I thought at that time, because we need a wire to actually penetrate the CTO segment, we put a wire in the side branch to block the side branch. Then what was in front of me was a CTO segment, which was very hard because it's a long time back, 9 months back, the angio was done. The same thing was there also. So we decided to take a wire with a good penetrability, with a good tip load. That's why we didn't take a channel seeking wire, sir.
No. That is the reason. I that is my suggestion. If you could take a channel seeking, if you try it, it would have been easier. Maybe that could cross easily.
Thank you, Dr. Ray and Dr. Banerjee for your comments. We'll move on to our next presentation, and I'll ask Dr. Prithviraj Bhattacharya, our expert panelist, to comment on the next set of cases to begin with. So I invite Dr. Mandar Shah, who's a good friend of ours, and he's the head of the Department of Cardiology and consultant cardiologist at Tata Main Hospital, Jamshedpur. And he's been to our Kolkata Live presentations before. So over to you, Dr. Shah, for your presentation. We can't hear you, Dr. Shah. You have to unmute yourself. Yeah, you can.
I'm so sorry. Am I audible now?
Yes, you are. And your slides are visible. Can you just maximize it?
Yes, I'll do that. Is this clear now?
Yes, a lovely picture of Tata Main Hospital. Thank you.
Thank you so much, sir. And good evening, everybody. And thank you for having me over here once again for this wonderful session on complex coronary interventions. It's always a great learning from all of you. So today I'm going to, if you permit me, I would like to present two cases.
Yeah, you have 15 minutes,
approaches.
Dr. Shah. It's all yours. If you can present two cases in 15 minutes, no issues.
Perfect. Thank you so much. So, as all of you would agree, calcium is #1 enemy for interventional cardiologists. Up to a quarter of patients with significant coronary artery disease have moderate to heavy calcification. And in significantly calcified lesions, there are immediate complications, procedure failures, as well as late failure due to malposition and under expansion, increased MACE. So I'll take you through two such cases. So my first case is an 81 years old gentleman, post CABG surgery in 1995 following crescendo angina. Lima2 LAD and RSVG2 PDA were put at that time. And now he presented with class 3 angina. He couldn't walk even for 5 minutes without getting anginal pain. His LV function was normal. So these are the native coronaries. You can see that the ostium of circumflex is a very critical lesion, almost a 90-95% lesion, and that's non-grafted vessel. So that obviously was the culprit. LAD is totally occluded from mid-segment. Perhaps that whatever is circumflex like is more like a ramus and a small circumflex is occluded from origin. And RCA once again is a totally occluded vessel. Lima 2 LED is widely patent, and we can see retrograde collaterals to RCA. The RSVG graft to PDA was occluded. So this is what we have, and because we are talking about calcium and calcified lesions, I would like to show you the amount of calcium that we had. So there is proper railroad sign which is visible, and all the coronaries are significantly calcified. So our aim was to deal with the culprit lesion, that is the ramus. So we began with whisper extra support wire, and we decided that was a time when we did not have IVUS in our lab. So this case is done without imaging. So we decided to go upfront with rotablation with so much of calcium, and you could see that the microcatheter did find difficulty in getting negotiated. So once microcatheter got negotiated, we exchanged it with rotawire, and then took a 1.25 millimeter rota, and at 1,60,000 rotations, we did a rotablation. But you can see we did it only the proximal segment, and then we exchanged the rotawire with whisper extra support wire. It was a normal length, not an extra length, exchange length wire. So that is the reason why we took help of this technique, which I think all of us by now are very acquainted with, wrapping the wire before removing the microcatheter. So then we did pre-dilatation with 2.5 by 12 non-compliant balloon, and as you can see over here, there is inadequate expansion. We stepped it up to 2.75 by 10 millimeters cutting balloon. And then this is angio shoot after proximal pre-dilatation. Now at this stage, there were differences of opinion within my team regarding whether we should just stent the proximal segment, keep it simple, 81 years old gentleman, distal lesion is not significant. So just stent the proximal portion from left main and come out. Or you can see the healthy segment is starting way down right over here. So should we address the distal lesion also? So eventually we felt that we already have all the armamentarium with us. We had rotablator already, all NC balloons were available. We did have Guidezilla with us. So then we said that it is better to give him a good result once and for all. And then we decided to go ahead with the distal lesion also. But I would want expert panelists' opinion on this, whether this was a right step or not. So then we did pre-dilatation with 2.5 by 15 non-compliant balloon. And then further pre-dilatation with a 3.30 by 8 non-compliant balloon. Then we took a 3.5 by 38 drug-eluting stent, but it was not able to negotiate in the distal segment. So we took body wire. Even with body wire,
sugar checker,
it wouldn't cross. We removed the stent. We dilated once again with 30 by 8 millimeter non-compliant balloon at very high atmospheres, almost 24, 26 atmospheres. Despite that, it wouldn't cross. So what was the option that we had? One option was to go ahead with rotablation. Worry was that there is tortuosity, it is circumflex. Sometimes if my rotablator crosses this, and due to tortuosity, I'm not able to freely move it and it gets stuck. That was one big worry. And incidentally, this happened to be the first rota of our cath lab. So we did not want to be over adventurous as well. So what we decided to do was what is called as a trapped wire technique. We already have a buddy wire in over here. So then we decided we'll inflate the stent right over here, and that will trap the buddy wire. And with the help of that trapped buddy wire, we should be able to cross negotiate the lesion. So that was the thought process. So till wherever the stent went, we pushed it, and we did deploy it over there. And then, of course, we did pot first, because we would not want stent hanging in left main without adequate opposition. Otherwise, whenever we take any additional hardware, it could hit the proximal edge of the stent and could cause deformation of the stent. So we did pot first, and then we decided we'll once again pre-dilate it with somebody's mic is on, please.
Can we unmute people who are not speaking, please? Thank you.
Right. So we did the pre-dilatation with 3/8 NC once again. This time we went up to 28 atmospheres. And then after this, the stent could easily get negotiated. And once the stent got negotiated, the trapped wire was removed, and the distal segment was stented. And then we did serial pre-dilate and post-dilatations and final pot. And this is the end result. Quite a satisfactory end result after all the Herculean things that we had to do. So this is pre and this is post. So certain discussion points. We could have, of course, used GuideLiner, GuideZilla. That was our next line of thinking. If we got stuck up, next point would have been to take a GuideZilla. We did not take rota distally. We were worried about burr getting stuck due to tortuosity. Once again, I would have opinions from expert panelists whether it is okay in a tortuous lesion to go distally with rotablator, and could we have avoided distal lesion altogether. Coming to my second point, he is a 65 years old diabetic gentleman with class 2 angina, and this is the only significant lesion that he had. And this gentleman, we had done angiography some 5-6 months earlier. At that time, this lesion was not as critical, and looking at tortuosity and calcification and relatively smaller area distally, we had kept him on optimal medical management. But he came with worsening of angina, and this time we had to address it because his angina persisted despite all optimal anti-anginals. Once again, to show you the amount of calcium. So we went ahead with wiring, and then we first took a semi-compliant balloon 2.5 by 15. And we did not have any difficulty in negotiating this balloon. So we thought hopefully we should be able to get the stent down. But the stent would not go even beyond the proximal segment. So then we took buddy wire. Despite buddy wire stent wouldn't go, then we took a 2.5 by 10 cutting balloon. Subsequently 3/0 by 12 non-compliant balloon. Still stent is not negotiable. So then we had to take GuideZilla, and we further upgraded the balloon 3.5 by 8 non-compliant balloon, once again at quite high pressures. And after this, the stent got negotiated. But you can see with so much of predilatation at high atmospheres proximally. The entire artery is badly dissected. The patient continued to have severe pain, angina, although he remained hemodynamically stable. So then we took a 3/38 drug-eluting stent, and then a third stent, 3.25/23 from the ostium. So once the distal stent got negotiated, subsequent stent did not have much problems. We had adequately prepared the lesion, did a post dilatation distally with a 3/0 balloon and proximally with a 3.5 balloon. And this is the end result. This is pre and this is post. Quite a satisfactory result. And this was done way back, I think 4.5 years ago, somewhere in 2016-17. And this gentleman is still coming to us regularly for follow-up, and he is doing exceedingly well. So take-home messages: with patience and proper hardware, calcified lesions can be successfully dealt with. Adequate lesion preparation is the key. And one or more of the following steps are necessary for successful outcome. Good guiding support. Sometimes deep throating of guiding is necessary. High pressure NC balloons. Now we have got OPN balloons which have bailed us out quite many times. Cutting balloons, scored balloons, buddy wire technique, shorter stents, rotablation, trap wire technique like we did in the first case, anchoring balloon technique, guidezilla or guide liners, and now latest to our arsenals are IVL balloons, orbital atherectomy, excimer laser, etc. So for our first case, we required all these steps. And for our second case, these were the things that bailed us out. So thank you.
Thank you, Dr. Mandar, for two excellent cases, and very well done for these two cases. I would invite for a short discussion before we move on to our next cases. I would like Dr. Prithviraj Bhattacharya, who did not speak in the first session, to start off with the discussion and then hand over to Dr. Shubhanand Ray for moderating the comments and the expert panelists. Over to you, Dr. Bhattacharya.
Yeah, thank you, sir. And it's a very nice two cases presented by Dr. Shah. I have a few comments. Firstly, congratulate Dr. Shah, because first case was this excellent case, considering it was the first case in the lab for rotablation. It's very tough case. Post CABG cases are notorious for calcium, and LCX is one of the most difficult arteries to deal with. And my question was, what was the body wire that he trapped with the stent to him?
It was a BMW. We deliberately did not use coated wire.
Okay. That was first. And regarding the distal lesion, did you have FFR at that time at your lab? That would have been one option to see whether that lesion is significant, because we didn't did a rotablation distally, and you are trying to put a stent. Better to get sure it is a lesion which needs something to be done.
Right. No, we did not have FFR at that point of time, although now we do have it. But that was a time when we did not have FFR. And actually, visually, it did not look a significant lesion, but there was a distinct plaque. And if we would have not covered the distal plaque, we would have required to put the distal edge of the stent in a relatively plaquey area. So that was the concern. But,
yes, but
visually, it did not look like a hemodynamically significant lesion.
Yes, that was the 2 point. And regarding the second case, definitely LCX, again, you cannot appreciate calcium all the time. There's sometimes calcium specules may be there, and because of the tortuosity, it will be difficult to negotiate the stents distally. And it was nicely done case, very nicely done. Thank you.
Thank you so much.
Dr. Shubhanand Ray. You're unmute. Please unmute yourself.
Very adventurous cases by Mandar, and congratulations for that. And
Yes, sir.
I have few suggestions again and few points to make. Never take a 1.5 balloon, 1.25 bar in a case where in a calcified artery which is tortuous and tortuous, calcified, and arterial girth and width more than 3. Your artery was very wide. Actually, it is the distal artery was more than 2.5, maybe 3. And you took a 1.25 bar. Actually, in a tortuous case, the bar to artery ratio should be 0.5 to 0.6, but not less than that. Otherwise, the chance of trapping will be more. The bar stock will be more in a tortuous artery if you take a very small bar, because it will move in, but it will never come out. As because it's a very small bar, it will go very easily. And as because there is no diamond chips in the proximal part, it will never come back. So for caucasus, we call caucasus phenomenon, and that is the reason why you should take at least 0.5 to 0.6 bar to artery ratio. The chance of bar stock will be less. This is number one. And number two is in a patient where there is an post CABG 85-year-old or 81-year-old patient, I think you could have done only the proximal part for the first case. And usually the calcified arteries, they do not produce unstable angina very often. Because if you look at the pathogenesis of unstable angina in a calcified artery, it is usually plaque erosion because it is solidified. It is calcified and there will be plaque erosion. There will be no plaque rupture. There is nothing to be ruptured, it is calcified. So it will be plaque erosion. And that is the reason they come with stable angina, not unstable angina on and off. So yes, that can happen, always happen with plaque erosion and thrombus, but they are less likely. So I think you could have done only the proximal lesion. Your adrenaline rush would have been less. And for the second case, I have one option. Do not go with the cutting balloon in very high pressure, because if you go beyond 14 to 16 atmosphere, it will behave as a semi-compliant balloon. That is the problem. That is why there was a costly dissection. So cutting balloon up to 14, 15, it will behave as a, even with the newer balloons, it will behave as a non-compliant balloon to some extent. And so that it is predictable. But beyond 16,
yes, sir, yes.
It will be unpredictable and it will behave as a, this thing, and chances of rupture will be very high. So this is one thing.
So no, sir, for this case also, we did not go beyond nominal pressures. In fact,
that's fine. That's fine. I thought that you went in for a very high pressure. And again,
we went with
that was a very tortuous
lesion. Non-compliant balloon.
Okay.
Yeah, with normal non-compliant balloon, we went at high pressures, 26 atmospheres. But cutting balloon, yes, sir, we as a policy do not go above nominal pressure.
This is one of the problems. Cutting balloon, even non-compliant balloons also, they do not behave non-compliant beyond the bursting pressure. They become compliant. Yes, so this is one of the problem. And otherwise, these two cases are very good cases. No problem. Absolutely.
Thank you, Dr. Ray. I think I agree with Dr. Ray about the distal lesion not being touched with. I think, being 81-year-old, so much of calcium, it looks stable to us, And so it's all, everything, every day we're learning. And I think it was the first rota case in your lab. So well done, Dr. Mandar. I think you did a good job on that. So we'll move on to our next presentation by Dr. Pranay Anil Jain. He's a good friend of ours and he's a consultant cardiologist at Ramakrishna Care Hospital, Raipur. So Dr. Jain, for your presentation, and the meeting is yours now. Please.
So, good evening, all the seniors. Thank you for giving this opportunity. So today I will be presenting a simpler case of a complex PCI and ACS and STEMI. So this was an 80-year-old gentleman He presented to us with acute pulmonary edema, ACS and STEMI. The troponin was more than 10 with high sensitivity troponin. BNP was more than 2000. And he is known case of diabetes since 45 years and hypertension of 30 years duration. And no addictions were there. He was a known case CKD, but he was on medical management with create around 6 or 5 or 6 before to admission. And at admission, it was around more than 8. So looking at the acidosis and this, the patient was started on hemodialysis. Echocardiography done showed moderate LV dysfunction with RWM in the elderly territory, but thickness was preserved. And there was no pulmonary hypertension at that time. But there was a thick chunk of calcium on the aortic wall with a pressure gradient of 11. So not much of aortic stenosis, but thick calcium was seen. So this was the angiography. And you can see thick chunk of calcium on the left main and the proximal LAD. And tight lesion in proximal and mid segment, long segment lesion was seen. Early ramus or early OM, you can say, was having lesion, but this vessel was distal. The lesion was quite distally. Similarly, RCA was also having thick chunk of calcium, but it was having around 70% lesion in the mid segment, proximal mid junction. And distally, there was diffusely diseased typical diabetic vessel in the RPD and PLV. So the issues to address were, this was an 80-year-old fragile gentleman. Family was not willing for CABG, and a presentation with acute pulmonary edema and NSTEMI with more than 10 troponins. So it was not like just an heart failure presentation. The enzymes were quite elevated also. Heavily calcified coronaries, diffusely diseased typical diabetic vessels. So he was stabilized for 5 days, given anticoagulation, antiplatelet. Hemodialysis was done 2 times in these 5 days. And the family was then was ready for PTCA with due risk and all. So this was the guide angiogram, and you can see a thick chunk of calcium in the proximal and mid LAD. So upfront, it was a case for rotablation. So we took a 7 French EBU 3.5, run through NS with a fine cross, and it was exchanged to rota floppy wire. The rota bar was 1.5 mm, and it was at 1,60,000 RPM. And you can see that mid proximal segment give away easily, but the mid segment was thick chunk that was not giving away. It took at least 90 seconds for me to get this thick chunk away. And then in the, this was the polishing run, which I have done. And now you can see it's easily going. And this was post-rotablation angiogram. Then exchange run through NS, rota floppy to run through NS over fine cross. So pre-dilated the whole lesion with 2.5 into 12 mm NC. The proximal segment was not giving away even at 18 atmosphere. So then used a 2.75 into 10 mm Wolverine at 14 atmosphere. As already sir has said, I had tried to avoid more than 14 atmosphere with the cutting balloon, and Wolverine with 2 blade is quite dangerous if you go at high atmosphere. So the lesion has given away. If you can see in the proximal segment, now the lesion has expanded, and even the balloon, there was no dogmoning was seen. So took a 2.5 into 48 mm DES, stented it from the ostium, checked in epicaudal, aleocaudal, and this is just cine I'm keeping from cranial view, but the ostial positioning was done in aleocaudal and epicaudal views. So then this was the final ostial positioning of the 3 into 10 mm DES. Now the dictum is to go from left main to LAD and try to avoid that distal LAD small plaque. But this 80-year-old fragile gentleman, I wanted to avoid the left main. So then post-dilated whole segment with 2.75 and proximal with 3 into 12 mm NC balloon. And this was the final result. So RCA, I thought was only 70% around lesion, and the patient was, it was planned to do RCA after 1 month, but the patient is coming back in OPD. He's doing well, no complaint of angina or any heart failure symptom. So I'm keeping the RCA lesion right now on medical management. So RCA, I kept it on medical management. I thought of doing RCA, I took guide also, but then I thought it's only around 70% and kept it on medical management.
Thank you, Dr. Jain. I think you have a very matured head on your young shoulders that you left the RCA for medical management. This is actually a coincidence that we have all the cases which are calcified cases. We have all the cases who are octogenarians, and nearly all of them had rotablation done. So this was not intentional. I think this is a kind of thing which has happened. So over to Dr. Shubhra Banerjee for your first comments, and then Dr. Shubhanandre for his comments, and then we'll take up the next. Over to you, Dr. Banerjee.
Yeah, thank you. I think the case was nicely done. The final images look quite good. Having said that, I would be always a little bit concerned about osteal position of a stent in a patient without having sort of a imaging facility, because I think there's a chance of missing the ostium. There could be some disease in the left main also. So, I mean, I would have really, I agree. You wanted to avoid the left main, that's fine in 80 years old. He may need to stop his antiplatelets any times, but still, in such a cases, I would have at least used an IVUS or an IVUS preferably, perhaps, to make sure that I'm in the right position.
We have IVUS facility, but because of cost, I was not able to do it, sir. Because ablation at our center cost around 1.5 lakhs. And because of that, even if I open an IVUS catheter also, then it costs some more charges, sir. Ox IVUS catheter I tried, but that images were not coming well. So that's why I'm not painting that.
Yeah, I know the finance at times makes it very difficult to really practice real science, but yeah, I'm just talking about science. And normally probably without imaging, I feel a bit uncomfortable in such cases.
Thank you, Dr. Banerjee. Dr. Shubhanandre, maybe we'll ask Dr. Pramod Kumar to give his comments, and over to Dr. Ray. Pramod Kumar. Dr. Ratnani, if you can give your comments. Dr. Ratnani? Okay. Dr. Ray, please give your comments.
I repeat the same thing what Dr. Deb already said, that Pranay has a very matured head on his young shoulders. That is the best compliment, perhaps. And it's a nice case. You have done nicely. And everything was fine. Yes, what Shubhra said is perfect, ideal, but always we cannot do ideal cases. But angiographically, your case is nicely done. I have got no comments about it. It's nicely done. Congratulations.
Dr. Bhattacharya, your comments?
Yeah, nicely done case, sir. No comments.
Okay, thank you. So we'll move on to our last presentation of the evening, Dr. R.K. Jha. He's a consultant cardiologist at Artemis Heart Center at Ranchi, and he's going to present to us a complicated bifurcation and complications. That's what I have on my chart. So over to you, Dr. Rajesh Kumar Jha, for your presentation. We're looking forward to it.
Yeah, good evening, sir. And I'm very thankful for giving me this opportunity to present this case. This was simple. Earlier, the patient was 40-year-old male and came with angina, and TMT was positive. ECG was some changes was present in the anterior lead and the old inferior wall amide. It looks like, and ejection fraction was almost normal. So we did angiogram, and the angiogram showed it was a triple vessel disease with right coronary artery CTO and filling from the retrogradely from LAD, and LAD and diagonal was disease.
So this was the angiogram. We can see LAD was diseased and RCA was filling retrogradely, and the diagonal was also diseased. So initially we planned for, we advised for CABG, but patient refused for CABG, and then uh, we had two options: either start with the CT or RCA and then LAD diagonal bifurcation or first bifurcation. So we decided to choose LAD diagonal bifurcation, and we planned for the simple mini crush technique as usual, normal everyday we do. And so I took BMW and two BMW wires. We dilated the diagonal and then dilated LAD. There was a lesion in the distal part, so we initially stented with 3.5 um, giants, 3.5, 38 giants expedition, and this was the initial result. And then we did mini crest stenting. So 2.5 uh, 2.5 into 23, and the LAD proximal stent was 4 into 23. So the first diagonal was inflated, and then the LED was in, stent was inflated. Then in the angiogram, we found that there was the LED was not inflated. The distal LED stent was not approximated. So we planned for post stenting dilatation with 4 into 8 millimeter balloon. So actually, it was a live case, and that time there was some comment from the opposite side that I should inflate this balloon. Actually, we inflated this at 18 mm. So still there was some. We can see here there is some lesion there. So we inflated up to 24 mm with 4 into 8 balloon, and this was the inflation. And then this nightmare came. We can see here the big rent in the LED. So immediately, since the balloon was inside, so immediately we inflated this balloon at the site, and then we started thinking what should be the next plan. Either we should use the cover stent, or we should wait for some more time inflation. So in this, we inflated the balloon for 10 minutes in the first time. Then we took one shot, and there was still the leakage was present. And so again, we plan to give inflation of 10 minutes for 3 sequential inflation. So after giving this 3 sequential inflation for 30 minutes, this was the result. We can see, and almost it was sealed. There was no leakage, and so finally we did the dilatation and then the kissing dilatation, and this was the final result. There is no any leakage, and the rent was sealed with the sequential inflation of 10 minutes, and this was the final result. So my message with this case presentation was that in the case in that sometimes if there is a big perforation, then we can manage the case without cover stent with the sequential inflation for 30 minutes, as per there is some guideline that 10 minutes of inflation if we will give for 30 minutes, then it can be sealed without the cover stent.
Thank you, sir.
Thank you, Dr. Jha, for your presentation. Um, it's wonderful to see, these kind of things which we have today. We had a lot of good cases today. So may I ask Dr. Uh, Dilip Ratnani to give his comments on this case, and then we'll move on again. Dr. Ratnani?
Yeah. The case was very well done, but just I wanted to know from him that before to proceeding for kissing balloon, why he attempted first post dilatation of the distal lesion. Means why sequence first. Usually we complete wherever we are concentrating. So just I wanted to know.
Yes, sir. Actually, it was distal stent, so I planned just to since there was didn't had any IVAS, so and it was visible that the stent was not inflated properly, and that's why I post dilated that stent, and then we planned for the kissing ballooning, and that was there was no specific reason behind that, and
And during prolonged inflation, was there any hypotension or angina?
Fortunately, patient was hemodynamically stable, but there was some angina, and we managed with morphine and nitrate. And blood hemodynamically, patient was stable. That was I was very fortunate because that may have led to the hypotension. But the patient was hemodynamically stable throughout, and we did inflation for 10 minutes of 3 sequential inflation, and uh, after this 3 inflation, we can see the result was very good, and there was
Usually, what has been observed that at that part distal LED going ahead with the 4 into 8 balloon, 4 balloon dilatation. I think one should be very, very careful, and we should not try to optimize it because I have also come across at least 2 cases where distal LED was being dilated and there was a perforation. So with a larger balloon, 4 into 8, it should be avoided. Number one. Second, there is always a fear of subsequently patient may going into means say bleeding starts and going into tamponade in ICU after say 6 hours. So it should be all these cases need very careful observation. Even if you have not done covered stenting, only balloon inflation has been done, and then you are skeptical of using heparin in these cases. So there are a lot of problems post PTCA period. First 48 hours, always you are in dilemma. Means you have to be very, very careful in such situation. But this is the site where I have seen usually there is perforation if you go with a larger balloon.
yes, sir. Actually, sir, we dilated with initially we dilated with a 4 into 8 at 12 to 14 only. But since it was a live case, and that time someone has prompted that we can go further, and so we just
Yeah,
dilated.
that's why That's
That
what I
was
was telling
definitely
you that one should concentrate on, in fact, the bifurcation, kissing there, and we divert your slightly. There was some prompt. You are basically, I should say, diverted because of somebody prompted. Otherwise, this was not in your plan.
usually, obviously, we don't do. But sir, on follow up, we did sequential echocardiogram, and we kept the patient for 3 days. Again, after 1 month, the patient came for follow up, and there was no residual pericardial effusion. And that time, very minimal pericardial effusion was there. And in the follow up, the patient was asymptomatic, and then we did RCA CTO also, and the patient is doing very good.
I just
Thank you.
wanted
Thank
to
you. Yeah.
just wanted to know from the expert moderator, sir, whether second DES at that means place uh, has been used sometimes, and the perforation has sealed after putting a second DES in that area, and because of fear of putting covered stent, because subsequently you may end up in restenosis. So that's why in one or two circumstances I've seen the second DES at that site also sealed the perforation. So what is your opinion?
I think if you do not have a covered stent which is appropriate to the size in your cath lab, I think that's the only option which you have probably if the prolonged balloon dilatation doesn't work. It has happened a few times that you have a perforation, do not have adequate sized covered stent in the lab, and the prolonged balloon dilatation did not work. So ultimately, somebody had to put another small stent. But that is not the recommendation, obviously. Now, since we have such an experienced panel here, and we have a case of perforation, I would like to throw up a question to the panelists. What are your management strategies? If you have a perforation in an artery which has not been stented, vis-a-vis if you, in this case where it was stented, would your management strategies be different, or would it be exactly what we already have? So over to you, Dr. Subramanian, maybe to start off, and then Dr. Subramanian.
Yeah, thank you. I think it also depends on the site of the perforation. I mean, if it's a distal perforation, maybe in a small branches, we can just even, it may not be suitable for a cover stent, very small maybe, but in such case, we can just embolize or, thrombose the artery. I think that may be one option, because the infarct that would be caused would be less of a problem rather than, of course, this is not possible if it's more proximal lesion, if it's a big artery. In that case, I think, cover stent is what I have used in the past. But this question, I think, is very interesting about what about using another DES? And I think, if you think about certain aneurysms, and people have actually done just without going for cover stent, even for small aneurysms of an artery, coronary artery, they have put a DES. And often it's been seen that the aneurysm closes. So I think if cover stent is not available, if it's not in a site where you can embolize, where you have tried prolonged balloon inflation and that hasn't really worked, the only option would be to put in a DES before really sending this patient for surgery.
Or in other cases, or I think if suppose there is a large branch arising near the perforation, then also second DES can be tried. That's what I think, because covered stent will block that artery.
Dr. Shobhanandre, your comments, please.
Unfortunately, in my career, I have seen a lot of perforation. So when I have tested the blood in my own, tongue. So basically, if you have a perforation through the stents and it is a free perforation, first thing I encountered is the tamponade. There's no doubt in it. If there is no tamponade, what are the plausible causes? You need to think of it, worried. It is a free rupture and there is no tamponade. Where the blood has gone?
Maybe in the left ventricle.
Yeah.
Maybe either it has gone to the left ventricle or it has gone through the myocardium. Probably that part of the LAD was intramyocardial. And that intramyocardial part, there was, seepage of the blood inside the myocardium, and that entered into the RV or LV, one of the chambers. Perhaps it happened just like that. And for the reason, when you inflated the balloon, it was sealed by the pressure of the muscles around and your balloon around. Otherwise, if it is a free perforation, it is impossible to stop the bleeding without any cover stent.
Covered stent, yes.
If you do not have a cover stent, what do? You make a cover stent. It's very easy. You take a balloon and you take a stent, right? Now you inflate the balloon, inflate the stent. You cut the balloon on the two sides, inflate the stent inside the balloon. And then you crimp the stent, balloon over the stent nicely. Go as a whole thing as a block. Dr. Shahu has shown such cases time and again. So he made all these types of cover stent on the table and put it inside the artery, because that is the only thing which can save you. Otherwise, I can tell you, if it's a free perforation, there will be tamponade, and if there is tamponade, it is very difficult to make the patient survive. So don't take it lightly. If there is a perforation, first thing you make, arrangements for a pericardial this thing. pericardial aspiration. Next thing, if you see that there is sizable pericardial effusion and hemodynamic deterioration, put a pigtail in. Then you think of a cover stent. If you do not have one, you make it. Go with your homemade cover stent as a block inside the artery. Inflate it. Come out with the stent balloon, and it will be there. It will look grotesque. We have seen Shah's cases a long time. It will look grotesque, but I can tell you, it will save your life, save the life of the patient.
So the balloon doesn't come off the stent when you're actually introducing it. It stays on.
No, you have to push the whole thing as a unit. Slowly go to the place where it is perforation happen, and inflate in a very high pressure. So there will be a sandwich between the stent and the balloon material outside. There is a stent already put, then a balloon cover, then another stent. So there will be a sandwich. Right. Okay, and you come out with the stent balloon. It doesn't look nice, but this is the only way you can protect it.
But if you do not have a stent previously in that area,
if you do not have a stent, then you have to. You are in a position to. Which is more dangerous. You just put a balloon there. What he has done. Put a balloon. Wait. That is the only thing you have. Or otherwise, you have to always have a cover stent on your shelf. That will help you out.
Yeah, I think not only having a covered stent, I think it is required that you have a lot of sizes of stents also. Because I think having a lot of labs have one covered stent, and it is always it happens that that covered stent is never adequate. So I think like we have balloons, like we have stents of different sizes, covered stents in an interventional lab of different sizes and dials are absolutely essential.
But another point is, these cover stents are very, very inflatable. If you see the covers in papyrus, it can be a 3 millimeter stent can be inflated to 5 millimeter. Believe me, this is the expansion limit. So if you take, at least you should have 1 or 2 sizes that could fit well.
Yeah, but the problem is in the tortuous vessels.
Yeah, tortuous is that is one of the biggest problem.
Dr. Ray, another question, which Dr. Ratnani very rightly pointed out. If you leave with the balloon inflation and come out, what would be your heparin protocol?
Yes, that is the most important thing. You need to.
That is a very difficult place. Yes.
You need to reverse the heparin before that. You put a protamine. The mathematics of protamine. 1 in 100, 1 milligram for 100 units. And you calculate according to that, and give protamine to reverse the heparin to some extent, not fully. Otherwise, there will be a clot. So if you have given either ACT is say 300, you gave at least 50 protamine, so that ACT is not very reduced, or between 100 to 120, 130s, and now you go. Otherwise, there will be a clot, and again that will be a problem.
I have a question, sir. That the few study has been done, and it says that the heparin reversal it should not be done with the protamine in the case of perforation if it is sealed with the balloon inflation for longer time. So, what is your say on that?
You see, basically,
because of that only, because of that. Yeah, because of that only.
Even in, you can see it in the TCT, last TCT, Dr. Colombo, when he did this thing, angioplasty of bifurcation angioplasty, and there was a wire-induced perforation and the tamponade. So they aspirated the tamponade, give a small dose of protamine, and put this thing. And look, there is no hard and fast rule in PCI. You have to use, if your ACT is very high, you need to use a protamine to make it a little low. Otherwise, there will be seepage. That is a problem.
Yeah, I did in my case ACT, and it was in between 300 to 310 or something. And with the prolonged balloon inflation, I had cover stent also, but I just planned for to give a longer inflation. And since I was fortunate that it got sealed and there was no significant tamponade also,
Yeah,
patient
that
was
is the reason.
hemodynamically
That
stable.
is the only great point about your case is you are extremely lucky not to have tamponade. Otherwise, the whole thing would have been topsy-turvy.
Yes, sir.
So I think we have come to the end of our presentation. So I'll ask Dr. Shubhanan Ray, our course director, to give a closing remarks and summarize the entire evening today, and then give a vote of thanks. Over to you, Dr. Shubhanan Ray.
I must say that it's a wonderful session. And first thing, I would give all credit to Dr. Dev for a wonderful moderation. He's a wonderful moderator and anchor. I think he is one of the best in this area. And also, I would congratulate every speaker. They have done very well, excellent cases, and good take-home messages. And and it is an excellent experience. And we gathered a lot of knowledge and a lot of wisdom from each case. And also, all very valued, comments from this. Our panelists like Dr. Ratnani, Dr. Pramod Kumar, Dr. Prithviraj Bhattacharya. We all very, valuable comments about the cases, and it's a wonderful session, an enjoyable session. So I must thank everyone for making it very successful, and also Aisha Kader. She was a wonderful presenter, and she presented a beautiful case. And I congratulate and I thank you all. And also I thank Abbott Vascular for giving us a chance to have a beautiful session. Thank you, everyone.
Thank you, Dr. Ray, for your closing remarks. Tomorrow, again, at 7 o'clock, we have a session on imaging and physiology, and I invite all our presenters and expert panelists to be also present tomorrow for a wonderful session. We have national experts on imaging and physiology like Dr. Prashant T.K. Sahu, Dr. Deepak Davidson. So it will be a wonderful evening tomorrow. So I invite everybody for tomorrow. So with that, I again thank all our presenters and our expert panelists and Abbott for giving us a platform and Kolkata Live to present these cases. And see you tomorrow again at 7 p.m. On 13th of February. Good night.